Hey everyone, my name is Joe. I'm one of the acute care PGY1 pharmacy residents at Moses Cone Memorial Hospital, and today we will be discussing myasthenia gravis. So by the end of this presentation, I want you to recognize the signs and symptoms of myasthenia gravis, understand the role of acetylcholine, acetylcholinesterase, and acetylcholine receptors in myasthenia gravis, kind of recognize the common medications associated with the development or exacerbation of drug-induced myasthenia gravis, and review those medications that we might use to treat myasthenia gravis. So what is myasthenia gravis? So it's an autoimmune disease characterized by fluctuating muscle weakness. It worsens with exertion and it improves with rest. Typically, it's associated with antibodies directed against the acetylcholine receptor. So the classic signs and symptom is asymmetrical extraocular weakness, defined as either ptosis or diplopia. So ptosis is this drooping eye, as you can see here. So one is lower than the other, and then we have this diplopia, which is double vision. As myasthenia gravis worsens, or you get a more severe form, you start to see more systemic signs and symptoms. So this tends to progress towards symmetrical proximal limb weakness. So you get both limbs that are affected at the same time. And then, at its most severe, you get respiratory, muscle, or oropharyngeal weakness. In other words, as these patients progress, it becomes more difficult to breathe, and you may actually see these patients intubated. So let's review the classic physiology. So under normal physiologic conditions, what happens here is that calcium comes in through the axon terminal, and it binds to this vesicle here. It allows the vesicle to fuse to the synapse, and then it releases acetylcholine. Acetylcholine can then bind to the postsynapse and allow sodium to enter. And if you remember your action potential, well, as soon as sodium enters, it causes a depolarization of the cell, and all of a sudden you get a contraction. So in myasthenia gravis, what happens here, we have these antibodies that are produced by B cells. And these antibodies are, again, typically targeted against the acetylcholine receptor. So even though we have calcium coming in, binding to the vesicle, releasing acetylcholine can't actually bind because these receptors are being bound up and destroyed. So then we have no muscle contraction at all. So what are the odds? So we have this scale called the Naranjo scale, and we use it when we suspect that a drug is causing a condition or exacerbating a condition. We will see this what's known as drug-induced diseases. So what this test does is it looks at the drug, it looks at the timing, and it uses this to give us a probability of the association or the odds that the drug is causing whatever ill effects we see. So things like, are there previous conclusive reports? If this is the first time you're seeing a patient present with this condition after this drug, odds are it's probably not associated with it, but you can go on down the list, and what happens is you get the score at the end. And so based off the score, it tells you if it's definite, probable, possible, or doubtful. And that's kind of how we, again, from a pre-test probability, look and see if the drug may be the contributing factor or the exacerbating factor. So here are some of the most common drugs associated with an exacerbation of myasthenia gravis. So penicillamine. This is an older drug. It's used in something called Wilson's disease. In Wilson's disease, what happens is there's an excess of copper in the body, and the body can't actually get rid of it. So what we do is we give penicillamine, and it chelates the copper. It also depresses T cell activity. Unfortunately, it does not do anything to B cells. So all of a sudden we have these B cells that are not being controlled by our T cell population. And these B cells are, which may have already been producing this acetylcholine receptor antibody, are now free to produce as much of this antibody as possible. Now we have interferon alpha, and interferon alpha is an older drug. You might have seen this more, or you might know this more with hepatitis. It's also used in certain types of leukemia and lymphoma. It's not so much used in hepatitis anymore, but there will be times in certain situations where we will use it particularly if the patient has a form of hepatitis C that is refractory to our current treatment modalities. So this interferon alpha is an interesting drug. So when a patient gets a viral cold, when they get the common cold, what happens is the virus attacks the cells and it works its way into cells, as all viruses do. And the cells release something called interferon. Well, interferon, one of the interferons, works to basically say, hey, we're being invaded by this virus. You guys next to me need to shut down so the virus can't get inside. And so what it does is, it tells the other cells to shut down, but it also sensitizes the immune system. And whenever you sensitize the immune system, remember there's this balance of turning the immune system on versus turning it off. And an extreme of either end results in either illness with immunosuppression when the immune system's off and it shouldn't be, or you have autoimmune diseases when the immune system is on and it shouldn't be. Next, we have this botulinum toxin. So mechanism, it prevents calcium-dependent release of acetylcholine. So remember back to our illustration how calcium has to bind to this vesicle to allow it to fuse and then release acetylcholine into the synaptic cleft. Well, botulinum toxin doesn't do this. I think we're most familiar with botulinum toxin, as a cosmetic treatment. Those people that essentially can't smile anymore because they got too many Botox treatments. So these are the three big drugs that are associated with myasthenia gravis. We have some other ones though. And these are actually the ones you'll see most often. So typically, these will be reserved in your ICU patients undergoing deep surgery, anything like that. So we have our anesthetics and our neuromuscular blockers. So let's go through the neuromuscular blockers first. These have the strongest correlation with myasthenia gravis, and the reason is very simple. They work to prevent acetylcholine from binding. And so if you remember myasthenia gravis, the whole thing is that we don't have enough acetylcholine receptors because they're being destroyed, and we have acetylcholine, but it has no place to bind. Well, it's the same thing with neuromuscular blockers. The non-depolarizing, work by and competitively binding to the receptors. And so it competes with acetylcholine, they fight it out, but typically the non-depolarizing neuromuscular blockers win out and you get paralysis. The depolarizing, there's only one to know, and this is succinylcholine. So succinylcholine is kind of interesting because it technically binds to the receptor and causes a muscle contraction, but then what happens is over time, under normal physiologic conditions, the body doesn't like to be stimulated for long periods of time. So this is especially true of the acetylcholine receptor at the neuromuscular junction. And what happens is the body says, okay, this receptor has been bound too long, I'm tired of receiving this stimuli, I'm done. And it takes a break. So between those two, you can see why these would exacerbate myasthenia gravis, because you're essentially doing the same thing pharmacologically that myasthenia gravis does because of an autoimmune disorder. Next, we have our inhaled and our local anesthetics. So let's go through the inhaled first. They're very simple. These work by enhancing the postsynaptic inhibitory channel, and they inhibit the excitatory channel. So they ramp up the do not fire signal and they turn down the fire signal. And the net effect is that you get this paralysis. These are all inhaled, and the ones that we have here, so isoflurane is more potent than sevoflurane, is more important than desflurane. That's just a clinical pearl. It's just kind of nice to know in case anybody asks you. The local anesthetics. So let's talk about the action potential for a second. If you remember, you have this net effect of either a excitatory or an inhibitory channel, and then it fires down the axon terminal, and here we have a myelinated neuron, and at the nodes of RON-VA, sodium comes in and it hyperpolarizes, and then that signal follows all the way down. So what these local anesthetics do are they actually block the sodium channels, and so if sodium can't get in, you can't propagate the action potential. If you can't propagate the action potential, well, then you have no effect. And so that's how they work to induce paralysis or exacerbate myasthenia gravis. So this is either after acetylcholine has bound or before acetylcholine has bound. Next, we're just going to run through some other drugs. These are things that I just want you to be aware of. So antibiotics are a big one. Aminoglycosides are the most indicated of the antibiotics to cause or exacerbate myasthenia gravis. Fluoroquinolones are next, and then you can kind of see here that there are others. I'm not going to read them to you. I didn't bother going super in depth. You guys will have your ID section or you've already had it. But I did put kind of some indications where you might see it. Then we have our cardiovascular drugs, and I'm not going to spend too much time on the antiarrhythmics, but the beta blockers I think are worth mentioning. As to why they cause it, there's no real information out there. So we have two different categories of beta blockers. We have our non-selective and we have our beta-1 selective. And so the non-selective that you might be most familiar with are labetalol or propranolol. And propranolol has the most uses outside of hypertension. So you'll see this typically with tremors, thyrotoxicosis / thyroid storm. And then you might also see it with variceal hemorrhage prophylaxis and migraines. Other than that, you have labetalol. It's mainly used in hospitals. You'll rarely see this as outpatient because it has to be taken 2 to 3 times a day. Then we have our beta-1 selective, and so the difference between a non-selective and a beta-1 selective is that the non-selective bind to all beta receptor subtypes. And so this is most important when you consider the lungs versus the heart. So the lungs have beta-2 receptors, 2 lungs, beta-2. The heart has beta-1 receptors. You have 1 heart, beta-1. And so the 2 here that are most indicated in myasthenia gravis are atenolol and metoprolol. You probably won't see much atenolol anymore. It's generally fallen out of favor. The data isn't as good, especially in heart failure. And so you don't see it used in heart failure. It is cheap though, and it is given daily. Now metoprolol is good. It's cheap. It's selective. It's $4 most places you go. However, it is dosed twice daily unless you use the extended release, which is unfortunately more expensive. You're looking at $15 to $30 for a 30-day supply, depending on how they take it. And this is the one that you use in heart failure. As for our antiarrhythmics, these are older drugs. You're not going to see them as much. The one thing I will mention about procainamide is that it is also associated with drug-induced lupus. And then here's some anti-epileptic and psychiatric drugs that you'll see, and I'll let you read that for yourself. There's not too much there. Just be aware that it can cause some neurotoxicity, muscular toxicity. So let's touch on the treatment real fast. I want to spend just a few minutes here. So here on the left, you can see this nice diagram. I highly encourage you to read through this. The point here is that we have a nice diagram that kind of tells us where to go with everything. So what are our treatment options? Well, we have our acetylcholinesterase inhibitors, our corticosteroids, and our immunomodulators. And then we have this IVIG down here, which isn't really for chronic treatment. So our acetylcholinesterase inhibitors. These are mainly used for symptom management. The big one we use is pyridostigmine. It has the longest half-life. It's typically the cheapest. The dose, you're looking at about 600 milligrams divided in 5 to 6 doses if it's the immediate release. If it's the extended release, you're looking at once to twice daily dosing, and you titrate to effect. So you don't just start at the highest dose, you go up and up as they need it. Now for the side effect profile, I want you to think about this. Let's make this as much common sense as we can because this is a lot of information. So when you think about cholinergic side effects, you think about sludge. You think about salivation, lacrimation, urination, defecation, GI cramps, emesis. So you're thinking about things that acetylcholine would do. So acetylcholine binds to most receptors and it causes sludge side effects. And this kind of makes sense because if you give Benadryl, if you give Dramamine, which is an anticholinergic, then it causes your motion sickness to decrease. You're not going to throw up as much, but you're also going to have some dry mouth. You're not going to want to use the bathroom as much in either way. It just generally drives you up. So neostigmine has a shorter half-life. It's also renally dose adjusted. I don't want you to focus on this one too much. Just know it exists. As far as the price, there wasn't any information available to me. This does have more potent side effects, so especially cardiotoxicity. And just another reason why you wouldn't really see it used, so pyridostigmine is the way to go. So if pyridostigmine doesn't work, then our next line is actually corticosteroids in combination with azathioprine. So we'll get into what azathioprine is in a second. This has been shown to improve muscle strength, but it does take a while to work. It takes about 2 to 6 weeks before you start to see an effect. And for our options, we have prednisone and prednisolone. You might be wondering what the difference is. So prednisone is converted to prednisolone in the body. The dose is typically 10 to 40 milligrams, but you give it every other day. So the side effects. So if you have had this before, you can kind of skip ahead. If you haven't, this will be a nice, very quick overview. So all corticosteroids can actually cause an exacerbation of myasthenia gravis. There is some muscle toxicity associated with corticosteroids. So you just have to watch out for that. There's also neurologic excitation. So I don't know if you've heard of it, steroid rage. People are generally just a little bit moody, if you will. Obviously don't tell them that. But you do want to tell them not to take it before bed because it's not just moody, it's hyper. Because cortisol ramps up your sympathetic nervous system, so you want to be sure that they're not taking it before bed, otherwise they're not going to sleep, and then they're going to be even more cranky. The other thing steroids do, they cause hyperglycemia, so we want to watch out for this in our diabetic patients. They also cause osteoporosis long term, and these patients are probably going to be on this long term. Causes immunosuppression, which makes sense because that's why we're using it. We're using it to suppress our immune system. And then it causes hepatic impairment. So, people with cirrhosis, any sort of liver problems, you're going to kind of want to watch out for them. And the last two things, I know this is skipped around a little bit, but the adrenal suppression and the Cushing syndrome. So adrenal suppression, basically you give high-dose steroids and it's a negative feedback loop, and so your body stops producing cortisol. Typically, it produces the equivalent of about 5 milligrams of prednisone a day. So when you give high doses, it tells your body, hey, we don't need any more, and so it stops producing it. And then with long enough treatment duration, you get this thing called Cushing syndrome. And Cushing syndrome, you can see this picture up here. We're kind of short on time, so I'll let you look into that. It is interesting, and you will see it in all steroids. Prednisone, corticosteroids are typically cheap. They're about $4 a month. So again, we use this in combination with azathioprine. So azathioprine blocks purine synthesis and DNA replication. This is typically for our rapidly producing cells, so our immune cells are very rapidly producing, especially our B cells, which, we're not going to get into why. I think that's beyond the scope of this lecture. Just know that there's a lot of DNA replication that goes on with immune cells. So this works to inhibit that. We see an onset of 6 to 15 months. So what happens is we'll give prednisone to kind of bridge to the effect with azathioprine, and we'll keep them on both. And then we'll titrate the prednisone or the prednisolone down to the lowest possible dose. So this is dosed at about 2 to 3 mg per kg. It's about $200 to $300 per month. And of course, you see leukopenia, which means low white blood cell count. Well, that makes sense because we're inhibiting the immune system. Then we also see some hepatotoxicity. We see, again, myelosuppression, which makes sense because we're inhibiting DNA replication, so your cells can't divide. And we also see an increased risk of infection because we're inhibiting the immune system. So this does carry a black box warning of malignancy with chronic use, so that's just something to be aware of. The other thing is that you do need to test all people for a deficiency of TPMT because a deficiency in this is associated with higher incidence of hypersensitivity reaction. So next we have mycophenolate mofetil, and this is for mild to moderate MG patients. So basically if they fail pyridostigmine, if they fail prednisone with azathioprine, then we're going to move on to mycophenolate. Mycophenolate inhibits DNA synthesis, which prevents T and B cell proliferation. This is typically given 1 gram a day, and it's pretty well tolerated outside of the immunosuppression, so you have to be aware of that increased infection risk. You also need to be aware that these patients need to wear gloves when they're taking this, and they should wear one glove, put the pill in their mouth, take it, take that glove off, and wash their hands. Nobody else should be handling this medication, especially when you're talking about pregnant women or women of childbearing age. Again, it is kind of an expensive medication. You're looking at $400 a month, but it's not first line, it's not even second line. Then we have our rituximab, and this is severe myasthenia gravis patients who require even more benefit. So if they're on mycophenolate and that's just not working, we go to this next. And this is an IV infusion. I'm not going to spend too much time on this. I would just know that you have infusion-related reactions, and we do worry about hepatitis B vaccination, so we do want to screen these patients for Hep B, but you're not going to see this outpatient. This is going to be in an infusion center. And then if all of that fails, we have our calcineurin inhibitors, which basically do the same thing as mycophenolate. As all of them, they inhibit the activation of our immune cells. So both of these actually are special because they're very potent. You'll see them mostly in transplant patients, and they do require therapeutic drug monitoring. So every once in a while, we'll call the patient in, we'll take some blood, and we'll look at the levels, and the levels are typically associated with efficacy and safety. Big side effects with tacrolimus, you have nausea, you have infections, again, makes sense. Then you have hypertension, you have neuropsych issues, electrolyte dysregulation, so you're going to want to monitor their magnesium, calcium, and potassium. And then hepatotoxicity and renal toxicity. It's expensive. Cyclosporin's the same thing. You do see more hypertension and hyperglycemia with this. You also see something called hypertrichosis. So the last one we have for treatment is methotrexate. This is another one where patients should wear gloves when taking. They should not let pregnant women or children handle this. It's highly toxic. Side effect, again, myelosuppression. So all of your immunosuppressive drugs cause myelosuppression. It also inhibits DNA synthesis for your immune cells. Again, those rapidly dividing cells. Outside of that, the special toxicities are lung toxicity and stomatitis. So stomatitis is typically when you see this inflammatory response in the oropharyngeal space, and it's very painful. Patients can't swallow. You end up putting them on something called magic mouthwash, and until it gets better, it's an awful thing. And then other than that, you have skin toxicity, including Stevens-Johnson syndrome, which is a medical emergency. Methotrexate, it says it costs about $2,000 a month. That's depending on what you put them on, what the dose is. You can get away with cheaper. It's just going to depend what their insurance covers and what their dose is. So finally, we have IVIG, and the only indication for IVIG is in myasthenia gravis crisis. So this is exacerbations associated with worsening weakness, which causes them to require intubation or non-invasive ventilation, i.e. BiPAP, things like that. Mechanism, so this binds to and inactivates autoantibodies, so think about those antibodies that the B cells are producing. And then if you prevent those from binding, then they're not going to bind to the acetylcholine receptor, and all of a sudden you're going to have these receptors that acetylcholine can bind to, and then you're going to be able to contract your muscles again. The adverse effects are generally infusion-related reactions. You will see some hepatotoxicity. You'll see acute chest pain and renal failure with this as well, so just something to monitor. And I know that was a little longer than it needed to be, but that is myasthenia gravis. In general, just understand your treatments. So first line is always symptomatic treatment, then you move on to prednisone with azathioprine. After that, depending on severity, you move down to mycophenolate, or you move down to rituximab being an infusion, and then you have your calcineurin inhibitors or methotrexate if you need for more severe. All right, so any questions, my email is on the front of this slide. You can email me, and I will get back to you before the class starts. Otherwise, I look forward to seeing you.